Hello, and welcome to lecture number 27. This is going to be our first in two lectures on antipsychotic medication. Excuse me. We'll start off talking in this one about schizophrenia and the neurotransmitter systems implicated in schizophrenia. Then we'll talk about historical background and classification of antipsychotics, and then talk about first-generation antipsychotics. In the next lecture, we'll cover second-generation antipsychotics and their side effects and some new developments and other uses for this class of drugs. So antipsychotics are primarily used to treat schizophrenia. There are a number of core features: prominent psychotic symptoms that are present for at least 1 week, poor psychosocial functioning, and mood disturbance is brief compared to psychotic symptoms. So it's more psychotic symptoms than mood disturbance. There are a couple of different phases identified in this particular disorder. Primarily, schizophrenia is diagnosed in late teens, early 20s, particularly in males. There can be earlier onset schizophrenia and later onset schizophrenia, but that's about the time in which most cases of schizophrenia are diagnosed. The premorbid phase of schizophrenia includes sort of subtle motor and cognitive or social impairments, so some working memory difficulties, attention difficulties, difficulty in social environments, appropriate social interactions. The prodromal phase includes mood symptoms, cognitive symptoms, social withdrawal, potentially obsessive behaviors. So we start to see degradation of social functioning, occupational functioning, and ability to sort of generally function in general. Then we get into the full syndrome of schizophrenia, which has substantial functional deterioration in self-care, work, and interpersonal relationships. So we have, can't keep up on house care or even bathing, feeding, lots of difficulty in that sort of basic self-care functioning. And what's important to understand about some of the cognitive disruptions are their difficulty in remembering to do things, remembering what they've done, trying to plan for the future, plan out how to accomplish a task, that sort of thing. It's characterized as a neurodevelopmental disease with significant abnormalities in brain structure and function, particularly in the frontal lobes. We see significant frontal lobe deterioration. There is a high heritability component. The primary view of schizophrenia is that it is an epigenetic disease. That is, there is a genetic risk factor that then is triggered by some sort of environmental event. And that has recently been linked to prenatal nicotine exposure. And we know that nicotine seems to have some kind of role in schizophrenia, in that a lot of schizophrenia patients smoke, and it does seem to, nicotine does seem to alter cognitive functioning in sort of a slightly positive way in these patients. And so there is potentially something to this dysregulation of nicotinic acetylcholine receptors. So the symptoms of schizophrenia are classically divided into both positive and negative clusters. And we mean positive not in the, oh, that's good sense, but in it's an addition, and negative in that it's a reduction. And so the positive symptoms include classic symptoms of schizophrenia: delusions, belief in being Jesus or the president, hallucinations, believing that God is talking to you, and other types of thought disorders. So these are the sort of hearing voices, classic hallucinations associated with schizophrenia. The negative symptoms of schizophrenia are oftentimes more difficult to treat, and also sometimes a little bit more important in terms of overall social functioning. So we have anhedonia, that is an inability to feel pleasure. They're withdrawn. There's a lot of affective blunting of emotional expression. We often refer to it as flat affect. And that anhedonia is part of the reason we believe this is a disease of dopamine, because we know dopamine is associated with our feelings of reward and pleasure. And so some of that disruption appears to be associated with these symptoms. Treatment focus for schizophrenia is improvement of cognitive functioning and quality of life, and social and functioning, etc. So trying to get patients to have a high quality life where they can take care of themselves, be in the community in either a group home or family setting, to get them feeling better and having a higher quality of life. So part of what we try to understand with treating schizophrenia are the neurotransmitter systems implicated in schizophrenia. And so we'll start with the primary theory, which is dopaminergic. This disorder is believed to have developed from dysregulation of dopaminergic brain pathways, resulting in overactivity of dopamine functioning. This evidence comes from a variety of lines of evidence, such as people who abuse stimulant drugs, such as amphetamine or methamphetamine or cocaine, and abuse them significantly, can produce a syndrome indistinguishable from paranoid schizophrenia, including delusions, hallucinations, and delusions of persecution in particular. We also know that antipsychotic drugs are primarily dopamine receptor antagonists that block dopamine receptors in the brain. So there is certainly an association with dopamine. We're still trying to get a handle on exactly how these neurotransmitter systems interact. And so we'll talk in future lectures about how we once thought about depression as being primarily about serotonin, and we now know it's actually about dysregulation of neurogenesis and connections between neurons. And so it's entirely possible schizophrenia has a similar type of etiology in terms of its underlying pathology. So dopamine released by neurons in the basal ganglia is crucial for maintaining normal coordination of movement. This is going to be important when we start talking about the side effect profile of antipsychotics, because that can be disrupted. But also individuals with schizophrenia do have some motor disruption as well. We also know that long-term chronic antipsychotic administration can elicit symptoms of abnormal motor functioning, which include extrapyramidal symptoms and tardive dyskinesia. And so these extrapyramidal symptoms can include things like tremors, similar sort of what we call pseudo-Parkinsonism, sort of shuffling along, inability to control movement as well, or tardive dyskinesia, which is a severe disruption in muscle functioning, which can include things like facial dystonia, which is sort of a grimacing facial affect as a result of these drugs. These second-generation antipsychotics, we can get the level of efficacy we want without the extrapyramidal symptoms or risk of tardive dyskinesia. And so these second-generation antipsychotics we'll talk about in the next lecture are often a much better choice because of their lower side effect profile. But they don't always work in every patient. So this is a trial and error type of treatment situation. So there's clinical evidence for dopamine involvement in schizophrenia. Antipsychotics block dopamine's effects, primarily at the receptor. The question is whether or not that's required for the therapeutic benefit, or is it related to the side effects? Exactly what's going on is a bit of a mystery. So we know in depression, for example, we can treat depression with drugs that have no influence on serotonin because they have influences on other neural processes. So it's entirely possible that something else is going on with these particular drugs. Certainly we know if a blockade is required for the therapeutic benefit, then drugs that are more potent clinically should also be more potent at blocking dopamine receptors. We do see that. So haloperidol, for example, is one of the most potent dopamine antagonists, and it is actually one of the most effective. We believe that serotonin is involved. There's 5-HT2 receptor antagonism that might be responsible for some of the beneficial actions of antipsychotics. It's also possible that the 5-HT2 antagonism plays an important role in improving the neurological side effect profiles of these newer antipsychotic medications. So it's possible that the serotonin blockade is helping the side effects, or it's helping the schizophrenia. We really are still trying to get a handle on exactly how this particular disorder comes about and exactly what's involved in the brain. There's clearly pretty good evidence for glutamate involvement in this particular disorder. Amphetamines, LSD, PCP, ketamine have provided some insight into the neurochemistry of schizophrenia because they can produce schizophrenia-like symptoms. In particular, PCP and ketamine can provide some of those classic schizophrenia-like symptoms. And we know these drugs block the NMDA-type glutamate receptors. And so there's a belief that this receptor is also involved in this. So if we think about how this might be coming about, let's take a look at this particular hypothesis with the glutamate NMDA receptors. The first is that there might be NMDA receptor hypofunction that results in excessive release of excitatory neurotransmitters such as glutamate and acetylcholine in the frontal cortex. And that then causes damage to cortical neurons, and an overall deterioration is triggered. We're going to see when we get to depression, this is fairly similar to the etiology of depression, where cortisol has this damaging effect, which causes a disruption in neuronal functioning, which then results in depression. And so it's entirely possible that this NMDA hypofunction is what triggers schizophrenia. So I'm going to provide a little bit of historical background and talk about the classifications of antipsychotic drugs. The first category of antipsychotic agents were the phenothiazines. They were initially developed as antihistamines. They do have a fairly mildly sedating action. Promethazine was the first phenothiazine. Chlorpromazine, which is Thorazine, was sort of the classic go-to drug for decades, used to treat schizophrenia patients. It has a very, very strong side effect profile. Thorazine is associated with sensitivity to the sun, lots of risk of extrapyramidal symptoms, etc. The second generation antipsychotics include the butyrophenones, such as haloperidol. Haloperidol is also one of the big go-to drugs for a long time. Droperidol, that's more associated with treatment-related nausea and vomiting. Clozapine or Clozaril, another new drug that had unfortunately fairly serious side effects and led to the development of other what we call atypical antipsychotics. These include Risperdal, Zyprexa, Seroquel, Abilify. Many of these I'm sure you've heard of, and we'll talk about those in more detail in the next lecture. So all the second generation antipsychotics differ pharmacologically from the first generation antipsychotics. They have relatively less affinity for the D2 receptors and greater affinity for 5-HT or the serotonergic receptors. They allow separation between antipsychotic efficacy and induction of extrapyramidal symptoms or other movement disorders. The conclusions of the comparative efficacy, safety, and cost-benefit ratio of the second-generation antipsychotics. Clozapine was superior to first-generation antipsychotics. Only olanzapine and risperidone appear to be better than the first-generation antipsychotics. Now, there's some criticism about these conclusions because of differences in dosage and difficulty in patient recruitment, but I do want to give you a little bit of a summary of a couple of big studies that were done in this area. So first is what's called the CATIE study. This is an 18-month study of almost 1,500 schizophrenia patients. Unfortunately, about 62 to 82% of patients stopped medication before the end of the 18th month study. Very typical in this class of drugs. They found out olanzapine resulted in more weight gain, which is another significant side effect. Olanzapine was slightly more effective. Pyrfenazine, equally effective to all the atypical agents. Risperidone and olanzapine, more effective than quetiapine and ziprasidone. And clozapine, more effective than other atypical agents in the treatment of schizophrenia. Unfortunately, clozapine also has a very heavy side effect profile. In the Cutlass study, we have 227 people who had inadequate responses or adverse reactions to their previous medication. Patients with schizophrenia did just as well on antipsychotic drugs from either category. Patients taking first-generation antipsychotics showed a trend toward greater improvement on the quality of life scale and symptom scores, and participants expressed no clear preference, and the costs were similar. So it's entirely possible that some of the first-generation antipsychotics might be the go-to drugs in this case. So the summary is there's no clear clinical advantages of second-generation antipsychotics over first-generation antipsychotics. There may be advantages in improved relapse prevention, reduced extrapyramidal symptoms, and tardive dyskinesia, and for use in bipolar depression. They are expensive in the second-generation group. They often are associated with weight gain and other metabolic problems. So that's a significant problem to consider, and we'll talk more about that in the next lecture. So let's take a quick look at the first-generation antipsychotic drugs. These are also known as major tranquilizers or neuroleptics. They are very good at alleviating the positive symptomology, but they don't have much effect on the negative symptomology, so we don't get rid of that flat affect. They sort of necessarily cause Parkinsonian side effects, so we generally almost always get those extrapyramidal symptoms and risk of tardive dyskinesia. There are a few non-psychiatric uses for these particular drugs. Almost never should be used except for in cases of psychosis. Control of nausea and vomiting, there's better drugs of choice for that sort of thing. These were the drugs of choice from 1955 up to about 1997, when we start to get switching to other different antipsychotics. But primarily, Haldol and Thorazine are the drugs from this first generation association. In terms of their pharmacokinetics, they're lipid-soluble, highly bound to protein and tissue with large distribution volumes. They have about a 20 to 40-hour half-life. They're extensively metabolized, and some metabolites are detected for months after discontinuation. So these drugs do stay in the body for quite a while, and so it's one of the problems we have to sort of monitor any potential issues with toxicity. So here's a full list of antipsychotic drugs. If you look here at the top at the phenothiazines, these are the sort of full list of those. Certainly Thorazine, Compazine. Compazine is primarily used for nausea. Mellaril or thyroidazine is another drug that I've seen used quite a bit when I was a psych tech back in the day, as we say. Then we get into the Haldol, very good drug of choice, and then the newer generation, which include clozapine or Clozaril, and then of course the other newer generation drugs. So you can see here their sedation, autonomic side effects, and involuntary movement profile. In the first generation, these are very high, much lower in the second generation, much higher to moderate sedation in these earlier drugs as well. So a summary of these. Most first generations block the D2 dopamine receptor, muscarinic, histamine, and norepinephrine receptors. By blocking those receptors in the basal ganglia, they produce those motor disturbances, acute extrapyramidal symptoms, and tardive dyskinesia. These side effects include what's called akathisia, which is a restlessness, so an inability to sit still. Dystonia, which is involuntary muscle contractions, which can be sustained, abnormal, bizarre postures of the limbs, trunk, head, and tongue, which can also be very disturbing. And then we get those neuroleptic-induced Parkinsonism, which is tremors, rigidity of the limbs, slowing of movement, and reduction in spontaneous activity. So one of the biggest difficulties with these drugs are the tardive dyskinesia. These are these involuntary hyperkinetic movements. It can be disabling. There's really no adequate treatment except for switching to another drug. Other side effects include some sedation. There is evidence that you get tolerance for. Hypotension, low blood pressure. Photosensitivity is another side effect of this. People who are on these drugs should avoid the sun. Some of the anticholinergic side effects include constipation, dry mouth, blurry vision, and some memory problems. So these drugs are not without a really significant side effect profile, but they are very good at treating schizophrenia and getting people back to at least functioning better. So these are the sort of major effects of the receptor blockades and which side effects they are causing. So the dopamine blockade is causing those extrapyramidal symptoms, norepinephrine, that postural hypotension, histamine, that's causing that drowsiness, potential weight gain, the acetylcholine causing a great deal of effects, and then the serotonin blockade is what seems to lead to weight gain in those second-generation antipsychotics. So haloperidol or Haldol was introduced in 1967 as one of the first alternatives to the phenothiazines. It does block the D2 receptors, but definitely causes Parkinsonism and other motor disorders comparable to those induced by those high-potency phenothiazines. So the receptor profile is the side effect profile very similar to the phenothiazines. Moban and Loxetane were introduced in the 70s. Loxapine binds strongly to both dopamine and serotonergic receptors. ORAP has been associated and used for treatment of motor and phonic tics in patients with Tourette's disorder. So individuals with those kind of motor tics oftentimes we put on this kind of antipsychotic to reduce those sudden bursts of motor movement with some success. All right, that's a quick introduction to the first generation antipsychotics. In the next lecture, we'll be picking up and talking about second generation antipsychotics.